All right, guys, Dr. Becker here again. We're moving right into chapter 71. I'm hopeful that you guys are listening to the osmosis videos. I've had a chance to review some of those concepts. We're jumping into drugs that weaken the bacterial cell wall, part 1, launching ourselves into the penicillins. The penicillins are practically the most ideal antibiotic because they are active against a variety of bacteria and their direct toxicity is low, which is nice. People tolerate them pretty well. The worst adverse effect that we can get from the penicillins is that people could have a true allergy to it. Penicillins have a beta-lactam ring in their structure, so they're known as beta-lactam antibiotics. Other beta-lactams are cephalosporins, carbapenems, and aztreonam. All of the beta-lactams, including the penicillin, have the same mechanism of action that they disrupt the bacterial cell wall, causing it to be able to lysis and leak. All right, so in order to understand the action of a penicillin, we must first really understand the structure and function of the bacterial cell wall, okay? Remember, the cell wall we touched on last lecture is a rigid, permeable, mesh-like structure that lies outside the cytoplasmic membrane. So inside the cytoplasmic membrane within the wall, the osmotic pressure is very high. So were it not for that rigid wall, which prevents expansion, bacteria would take up water, swell, and then burst. Penicillins work by weakening the cell wall, causing the bacteria to then take up excessive amounts of water and rupture, and as a result, the penicillins are generally bactericidal. So we talked last lecture about the difference between cidal and static drugs, okay? So our penicillins are bactericidal. That's why they can be so very effective, as they are working on directly killing the bacteria and preventing them from working and growing and multiplying. Penicillins weaken the cell wall by two actions. One, inhibition of the transpeptidases. So you can see here, inhibition here. And two, disinhibition or activation of the autolysins. So transpeptidases are enzymes critical to cell wall synthesis. Specifically, these transpeptidases catalyze the formation of cross bridges between the peptidoglycan polymer strands that form the cell wall. And thus they give the cell wall its strength. So these transpeptidase material are kind of like the strands within a muscle, keeping it tight and taut and kept together. So if I give the penicillin, it weakens and inactivates the transpeptidase, making that a very weak and not as tightly structured wall. The autolysins are bacterial enzymes that cleave bonds in the cell wall. And so bacteria use those enzymes to break down segments of the wall to permit growth and division. So by simultaneously inhibiting the transpeptidase and activating the autolysins, the penicillins disrupt synthesis of the cell wall and promote its active destruction. Okay, so if someone were to ask you, how do penicillins work? We would say they are beta-lactams. They have a rigid, permeable cell wall. When I give a penicillin, it does two things. It inhibits the transpeptidase, meaning that they weaken the wall, and it activates the autolysins, promoting the active destruction of the bacteria. So together, that results in cell lysis and death. Okay, so the way that penicillins work is they weaken the cell wall, rupture the cell wall, and trigger autolysis and cell death. The molecular target of the penicillin, right? so that's the transpeptidases, the autolysins, and some of the other enzymes, are collectively known as penicillin binding proteins, PBPs. PBPs molecules are so named because penicillins must bind to them to produce antibacterial effects. So in this next figure here, 71.2 in your book, the penicillin binding proteins are located on the outer surface of the cytoplasmic membrane. Okay. More than 8 different penicillin binding proteins, 8 different PBPs, have been identified. Of those, PBP1 and PBP3 are most critical to penicillin's antibacterial effects. Bacteria express the penicillin binding proteins only during growth and division. So, because penicillin binding proteins must be present for penicillins to work, the drugs only work when the bacteria are growing. These are those PBPs, penicillin binding proteins in our cytoplasmic membrane as part of the cell wall. So these only show up on the cell wall during growth and division. But this is what the penicillin is targeting. So if you're not having growth and division, you're not going to have an effective penicillin. Note that the gram-negative cell envelope has an outer membrane, whereas the gram-positive envelope does not. So the outer membrane here of the gram-negative cell prevent certain penicillins from reaching their target molecules, the PBP. Okay, so there's a difference between treating a gram-positive bacteria versus a gram-negative bacteria. Gram-negative can be more challenging because they have another outer wall here that make it more difficult for the penicillins to find the PBPs. Because mammalian cells lack a cell wall, and because penicillins act specifically on enzymes that affect the cell wall integrity, the penicillins have virtually no effect on cells of the host. That's why they're considered the most safest antibiotics. So if you think about it, penicillins, right? If we're telling you penicillins are super safe, why? Because they have no direct effects on the cell host, and they're bactericidal. They're actively killing off the bacteria themselves. They're very effective. So we have to be really careful to use them appropriately because we don't want to lose them to resistance. So how do we develop bacterial resistance to penicillins? All of the bacterial resistance to penicillin is primarily determined by 3 factors. 1, the inability of the penicillins to reach the PBPs. 2, inactivation of the penicillins by bacterial enzymes. And 3, production of the PBPs that have a low affinity for penicillins. So in our last chapter, we talked about all these different ways that resistance can have. So if the microbe gets smart, okay, 1, it could say, we're going to create a way so that the penicillin cannot reach the penicillin binding proteins. That would be effective. If the penicillin can't get to the spot it needs to get to, well, then we're out of luck. 2, I could send out some killers out there and actually kill off the penicillin and make it useless and inactivated before it ever has a chance to reach the PBPs. Or I could create PBPs that have a low affinity for penicillins. So a simple example of that, just for my brain and how I would think of that, is that let's say the PBPs are usually a fluorescent hot pink, so that my penicillins now, when I give the drug, they say, go and find the really hot pink port and latch on to that. But if the bacteria gets smart and they say, okay, well, if I give this change to it and I change it to a really light pink, almost pale white color, then the penicillins aren't going to be able to find it as easily. So even though it's still pink, I've changed it enough that they can't find it. So now I give the penicillin and it ain't working. It has now become resistant because the bacteria got smart. Okay. Gram-negative cell envelopes. So if we go back to the gram-negative cell envelope, we have that extra outer membrane. All bacteria are surrounded by a cell envelope, but the cell envelope of gram-negative organisms differs from that of gram-positive. Because of that, some penicillins are ineffective against gram-negative bacteria. The cell envelope of the gram-positive bacteria has only these two layers right here: the cytoplasmic membrane and a relatively thick cell wall like we've talked about. But despite its thickness, the cell wall can readily be penetrated by penicillins, given these are the penicillin molecules coming, so they break through that, they destroy that transpeptidase, and they turn and they bind here and they trigger the autolysine. The gram-negative cell envelope has three layers. Okay, we have the cytoplasmic membrane, a relatively thin cell wall, but they have an additional outer membrane. So like the gram-positive cell wall, the gram-negative cell wall can easily be penetrated by penicillins. However, the outer membrane is difficult to penetrate. So as a result, only certain penicillins, such as ampicillin, are able to cross it and thus reach the PBPs on the cytoplasmic membrane. So if we are empirically treating an infection and we give a penicillin, and then we find out that it's a gram-negative bacteria, we maybe will find that the penicillins aren't effective. Okay. The other thing we said before was that maybe the penicillins will be inactivated by bacterial enzymes. So beta-lactamases are those enzymes that cleave the beta-lactam ring and therefore render penicillins and other beta-lactam antibiotics inactive. Bacteria produce a large variety of beta-lactamases. Some are specific for penicillin, but some are specific for other beta-lactam antibiotics like the cephalosporins. Beta-lactamases that act selectively on penicillins are known as penicillinases. Remember, ases are enzymes typically. So penicillinases are synthesized by gram-positive and by gram-negative bacteria. The gram-positive organisms produce large amounts of these enzymes and then export them into the surrounding medium. So in contrast, gram-negative bacteria produce penicillinases in relatively small amounts. And rather than exporting them to the environment, they secrete them into the periplasmic space. Okay? So if these are our penicillinases, this is what they're talking about. In the gram-negatives, they tend to put them in that space there. The genes that code for beta-lactamases are located on chromosomes and on plasmids, which are extrachromosomal DNA. The genes on plasmids may be transferred from one bacteria to another that helps promote the spread of penicillin resistance. Transfer of resistance is of special importance with Staphylococcus aureus. So when penicillin was first introduced in the 1940s, all strains of Staph aureus were sensitive. However, by 1960, 80% of Staph aureus isolates in hospitals were penicillin resistant. Fortunately, a penicillin derivative, methicillin, that has resistance to the actions of the beta-lactamases, these things here. Was introduced. So to date, no known strains of Staph aureus produce beta-lactamases capable of inactivating methicillin or related penicillinases resistant penicillins. That's a lot. The other one that we talked about is altered penicillin binding protein. So if they altered the PBPs, right, now it becomes really hard for the penicillins to find where they're supposed to bind. So certain strains known as MRSA, methicillin-resistant Staph aureus, have a unique mechanism to be resistant. They produce PBPs with a low affinity for penicillin and all other beta-lactamase antibiotics. So MRSA developed this ability by acquiring genes that code for low-affinity PBPs from other bacteria. Okay, so let's talk about MRSA. Staph aureus is a gram-positive, so we're in the gram-positive side bacterium, that typically colonizes the skin and the nostrils, even in healthy people, of all people. Infection, though, typically involves the skin or soft tissues. We see abscesses, boils, cellulitis, and impetigo. However, more serious infections can develop along the lungs and the bloodstream, which can be fatal. Highly resistant bacteria known as the MRSA are resistant not only to methicillin, but now to all penicillins and most cephalosporins as well. The basis of MRSA resistance is acquisition of those genes that code for PBPs that have very low affinity for penicillins and cephalosporins, meaning if I give those drugs, they cannot find those PBPs. They've altered them to the point where the penicillins can't find them anymore to activate and work. We used to only have healthcare MRSA, and now we have community-acquired MRSA. Healthcare-acquired MRSA is usually through person-to-person contact, often between healthcare workers and patients. So risk factors for that include older age, recent surgery, hospitalization, dialysis, treatment in the ICU, prolonged antibiotic therapy, an indwelling catheter, or being a resident in a long-term care facility. So we have drugs that are specific to MRSA, and I'm not going to go into great detail of that right now. Community-acquired MRSA is also a big deal. It's considered to be less dangerous than the healthcare-acquired, but it's more dangerous than we'd like to say, right? Community-acquired MRSA is mostly by skin-to-skin contact or with contaminated item. Could be like sharing sports equipment or personal items like razors. That's like impetigo and stuff. If you have that skin infection, it's a staph infection, and then you can't wrestle because you can't do skin-to-skin contact with other people, or we're going to spread that, as an example. One thing to remember, we do actually have one cephalosporin that is active against MRSA, whether it's healthcare or community acquired, and that is the 5th generation cephalosporin, ceftaroline. So if you were to ever have a question, what beta-lactam drug does work against MRSA? And that answer would be our 5th generation cephalosporin, ceftaroline. So now to talk about the penicillin classification. The most useful classification is based on the antimicrobial spectrum. So we have 4 major groups: narrow spectrum that are penicillinase sensitive, narrow spectrum that are penicillinase resistant, broad spectrum penicillins, and extended spectrum penicillins, which are also called the anti-pseudomonal penicillins. So table 71.1 in your book goes through those. That could be very helpful as well. I'm sorry, I didn't flip through my slides fast enough. Okay, the properties of the individual penicillins. So penicillin G is benzyl penicillin, penicillin G, or penicillin V. Those were some of the first penicillins available, and we consider that the prototype of this book. When we say penicillin, we're referring to penicillin G, essentially. It is bactericidal to gram-positive bacteria and gram-negative bacteria. Despite having these new fancy antibiotics, penicillin G remains a drug of choice for many infections. Don't discount it, don't discredit it, and don't forget it, okay? It's still a very good drug. It's active against most gram-positive bacteria, gram-negative bacteria, anaerobic bacteria, and spirochetes. With few exceptions, gram-negative bacilli are resistant. It's considered a narrow spectrum compared with the other penicillins. Penicillin is available as 4 salts. So you may hear it as potassium penicillin, procaine penicillin G, benzathine penicillin G, and sodium penicillin G. The difference is that these salts differ in the route of administration and time of action. So with all the forms, though, the salt dissociates and releases the active penicillin. So you can give penicillin intramuscularly, okay? It is important to note that the different salts are done at different rates. So we can see that here, hours after administration, the potassium and sodium penicillin versus the procaine penicillin versus the benzathine penicillin. So potassium and sodium penicillin G is rapid. The blood levels peak 15 minutes after injection. But the procaine and benzathine salts are absorbed slowly and hence are considered repository preparations, so that when the benzathine is administered IM, it's absorbed for weeks, producing blood levels that are persistent but very low. This preparation is really useful against highly sensitive organisms like bacteria that cause syphilis. We don't see that quite as often anymore. Okay, the penicillin G, penicillin V distribute well to most tissues and body fluids. In the absence of inflammation, the penetration of the meninges into fluids of joints and the eyes is poor. By contrast, in the presence of inflammation, entry into cerebral spinal fluid, joints, and eyes is enhanced, permitting treatment of infection caused by susceptible organisms. So that's unique. It's excreted by the kidneys. Mainly, the half-life is typically very short. Renal impairment causes the half-life to increase dramatically, so you may need a reduction in dose. If they're at high risk for toxicity, such as renal failure, acutely ill, very young, or very old, you should monitor their kidney function closely. Penicillin G, penicillin V are the least toxic of all the antibiotics and the safest of all medications. Allergic reactions really the only principal concern. Some people have pain at the IM site. Some people may have sensory and motor dysfunction if you accidentally inject it into the nerve. If you get too high of the blood level activities, you could get neurotoxicity. If you accidentally gave it into an artery, which would be interesting, you could produce severe reactions like gangrene or necrosis. Sometimes the adverse effects actually come by the compound co-administered, like the salts. So procaine G may cause bizarre behaviors when the procaine penicillin is given in large doses. When large doses of the potassium penicillin are administered rapidly, you could get hyperkalemia, right? So you have to be careful with some of those things. Sodium penicillin G would be used in caution in patients on sodium-restricted diets, right? Because you're giving a large amount of sodium salts. Penicillins are the most common cause of the drug allergy, which we said. So, as with true allergies, there's no direct relationship between the size of the dose and the intensity of the response. So, although prior exposure to penicillins is required for that true allergy, responses still may occur in the absence of prior penicillin use because patients may have been exposed to penicillins that are produced by fungi or to penicillins present in food of animal origin. So in other words, it is completely possible to have a true allergic reaction to penicillins without ever having been given, quote unquote, a penicillin. Because of cross-sensitivity, similar structures, etc., patients allergic to one penicillin are considered allergic to all. And there are about 1% of true allergy to penicillin patients, only 1%, have a cross-sensitivity to cephalosporins. So, if at all possible, patients with a penicillin allergy should not be treated with any of the members of the penicillin family. But the use of cephalosporins really depends on the intensity of the allergic response. So if the penicillin allergy is mild, you could probably use a cephalosporin. But if it's a true allergy, it's a severe allergy, they truly had anaphylaxis, they should probably avoid a cephalosporin. There are different types of allergic reactions to the penicillin, such as immediate, accelerated, or delayed. Immediate occurs 2 to 30 minutes after you get the drug. Accelerated occurs with 1 hour to 72 hours, and delayed occurs with days to weeks. The immediate and accelerated reactions are caused by IgE antibodies. Okay? Anaphylaxis is an immediate hypersensitivity reaction occurring more frequently with penicillins than any other drug. I think I've said that 9 times. However, even with penicillins, the incidence of anaphylaxis is still really low, you guys. It's really low. It's like between 0.004 and 0.04. But when the reactions do occur, 10% can be fatal. So we take that very seriously. The primary treatment, of course, is epinephrine. Typically, within 30 minutes, you should see signs of anaphylaxis if it's true anaphylaxis occurring. You can do skin testing to truly see if someone has a true allergy to penicillin. If you have a patient who says, yes, they're allergic to penicillin, you have to kind of do a deep dive. If they answer yes, the general rule then is to avoid penicillins. If the allergy is mild, you may be able to use a cephalosporin. If there is a history of anaphylaxis or some severe allergy, it's prudent to avoid the cephalosporins as well. When a cephalosporin is indicated, an oral one is preferred because the risk for severe reaction is lower than with parenteral. However, you can use vancomycin, erythromycin, or clindamycin that can be a very safe and effective alternate drug to the penicillin. Rarely, you may have someone with a history of anaphylaxis who now has a life-threatening infection. And so sometimes, in those cases, the benefit of the penicillin outweighs the risk, and treatment should be started, and you should be able to dose it very specifically to a desensitization schedule. That is a very rare thing, but just know that it could be done. Penicillin V and penicillin G are different mainly because penicillin V has acid stability. So penicillin V is stable in stomach acid, where penicillin G is not. So penicillin V is what we give for oral therapy, and penicillin G is typically what we take with the parenteral routes. Penicillin V, as in Victoria, may be taken with meals to really help any GI upset. Okay. Broad spectrum penicillins, aminopenicillins. Okay. We have 2 broad spectrum penicillins. So if you were to ask or be asked, what's the difference between penicillin G and ampicillin? One of the first things you could say is that penicillin G is narrow therapeutic spectrum, and ampicillin is a broad spectrum penicillin. Okay, our two broad spectrum penicillins are ampicillin and amoxicillin. Both have the same antimicrobial spectrum as penicillin G, but also have increased activity against certain gram-negative bacilli, such as H. flu, E. coli, and Salmonella, and Shigella. So this broadened spectrum is mainly due to an increased ability to penetrate the gram-negative cell envelope. So our broad spectrums, ampicillin and amoxicillin, do really well at penetrating this part here. Penicillin G, penicillin V, not so much. We want broad ampicillin and amoxicillin to penetrate the gram-negative envelope. Both drugs are readily inactivated by beta-lactamases and therefore are ineffective against most infections that are Staph aureus. Okay, ampicillin was the first one to come into use. It is very effective, but it can cause rash and diarrhea. Those rash and diarrhea occur more frequently with ampicillin than with any other penicillin. Okay, rash, diarrhea, ampicillin. If a rash occurs, the provider should evaluate the difference between a non-allergic rash and a rash related to hypersensitivity reaction. A non-allergic rash with ampicillin is in 5 to 10% of children. The rash generally appears 3 to 10 days after initiation of ampicillin therapy, whether it's oral or IV. It should be noted that for oral therapy, we typically use amoxicillin. So you could get a rash, you could get diarrhea. It is possible to have a non-allergic rash as well. So just because it's a rash doesn't mean that you automatically have an allergy. Okay. So table 71.2 in your book goes through the narrow spectrum penicillins and the broad spectrums and kind of defines that there. The extended spectrum penicillin, which is an anti-pseudomonal penicillin, is your piperacillin and tazobactam, which is Zosyn. So Zosyn's a great drug to use like in intensive care and in critically ill patients because it has an anti-pseudomonal effect. You have to watch for renal dosing though too for these drugs. All right, amoxicillin is very similar to ampicillin. The two drugs differ in acid stability. Amoxicillin is more stable, therefore you can give it orally in equivalent doses. So if you have to give it orally, amoxicillin is preferred. Amoxicillin causes milder diarrhea than ampicillin, so that's a good thing, right? We also give amoxicillin with clavulanic acid, which is an inhibitor of bacterial beta-lactamases. So when you give amoxicillin plus clavulanic acid, that's called Augmentin, and that can be one of our really potent drugs to give. Remember that piperacillin is given in immunocompromised people, people that are really sick, people that need anti-pseudomonal agents. Piperacillin itself is a penicillinase sensitive drug. It's highly active against Pseudomonas, its principal target. Piperacillin can cause bleeding secondary to disrupting platelet function. The drug is acid labile, so it has to be given parenterally. It has to be renally dosed. When we give it with tazobactam, it's called Zosyn, and that is a beta-lactamase inhibitor. So beta-lactamase inhibitors like clavulanic acid and tazobactam are drugs that inhibit bacterial beta-lactamases. So by combining those with the penicillin drugs, we extend their spectrum of use. In the United States, we have 3 beta-lactamase inhibitors. We have sulbactam, tazobactam, and clavulanic acid. Okay, so if we have ampicillin with sulbactam, it's called Unison. If we have oral amoxicillin with oral clavulanic acid is augmentin, and then parenteral piperacillin with tazobactam is zosyn. So you can give ampicillin or you can give ampicillin plus sulbactam. The reason you would want to give the ampicillin sulbactam is it has the wider range of drugs it's going to get, because the sulbactam is a beta-lactamase inhibitor. So those drugs and theories could work against drugs or bugs, the bacteria that are beta-lactamase. Because the beta-lactamase inhibitors have minimal toxicity, if you do get a reaction, it's most likely from the penicillin portion of the drug and not the beta-lactamase inhibitors. And there you go. That is our chapter 71, Drugs That Weaken the Cell Wall, Part 1. Now, hold on. Go right into chapter 72, which are Drugs That Weaken the Bacterial Cell Wall, Part 2. Okay, so like the penicillins, there's other drugs that can disrupt the cell wall, produce bacterial lysis and death, and are considered bactericidal. Specifically, this chapter focuses mainly on the cephalosporins, but also touches on vancomycin, telavancin, and fosfomycin. Okay. These drugs we're about to talk about are similar to the penicillins because they inhibit cell wall synthesis. By disrupting the cell wall, these drugs will cause lysis and death. Cephalosporins. Cephalosporins are beta-lactam antibiotics similar in structure to the penicillins. They are bactericidal, so they are actively killing the bacteria. They are often resistant to beta-lactamases, but they're active against a broad spectrum of pathogens. Their toxicity is low. They're pretty well tolerated. They're popular therapeutic agents, and they really are one of the most widely used groups of antibiotics. Cephalosporins, as a hospitalist, are my best friends. I use them a lot. Mechanism of action. The cephalosporins are bactericidal drugs with a mechanism similar to that of penicillins. So they work by binding to our penicillin binding proteins, and therefore they disrupt the cell wall synthesis and they activate the autolysines that result in cell death. Just as with the penicillins, cephalosporins are most effective against cells undergoing growth and division, because that is when the PBPs are released. The principal cause of resistance to the cephalosporins is also beta-lactamases. Those are the enzymes that cleave the beta-lactam ring and thus render these drugs inactive. Beta-lactamases that act on the cephalosporins are sometimes referred to as cephalosporinases. We just have to make everything complicated, don't we? Some of the beta-lactamases that act on the cephalosporins can cleave the beta-lactam ring of penicillins. So we have different generations of the cephalosporins that have been created. First generation is literally the first go-round creation of the cephalosporins. And as we've created the new generations, we've gotten better with the drugs that can do more. So our first generation cephalosporins are destroyed by the beta-lactamases. Our second generation cephalosporins are less sensitive to destruction. Third, fourth, and fifth generation cephalosporins are highly resistant. So in some cases, bacterial resistance results from producing those altered penicillin-binding proteins that have a low affinity for the cephalosporins. Methicillin-resistant staphylococci produce these unusual PBPs and are resistant to most cephalosporins, except for ceftaroline. Our fifth generation cephalosporin is active against MRSA. Okay, so we group these into 5 generations. First generation prototype is cephalexin, also called Keflix. It has low activity against gram-negative, low resistance to beta-lactamases, and poor distribution to the cerebrospinal fluid. Okay. You are not going to give cephalexin to treat meningitis, in other words. Then we have our second generation An example is oral cefoxitin or ceftriaxone, which is a very common drug, Rocephin. These have higher activity against the gram-negatives. They have high activity or high resistance to the beta-lactamases, but also have poor distribution to the CSF. I'm sorry. Gee, Merry Christmas, you guys. It's been a long day. Ceftriaxone's a third generation. I'm really slow on the uptake. So second generation is the cefoxitin. Third generation is cefotaxime or cefuroxime. And the third generation parenterally is ceftriaxone. The third generation has good cerebrospinal fluid penetration and distribution, and high gram-negative and high resistance to the beta-lactamases. Fourth generation is cefepime. That's a drug we see a lot in the hospital. That has the highest gram-negative bacteria activity, highest resistance to beta-lactamases, and really good cerebrospinal fluid distribution. And then our fifth generation also has high activity against gram-negative and high resistance to beta-lactamases. Okay. Many cephalosporins have to be given parenterally, which is IV or IM, we know that. Only 10 can be administered by mouth, and only one, cefuroxime, can be given both by mouth and by injection. So, for example, let's say in the hospital your patient was getting ceftriaxone and now you wanted to convert to oral, you would go to a third generation. So if the ceftriaxone was working, it was sensitive, it was doing its job, but you wanted to give them oral to go home on, maybe that's when you would give them cefotaxime or cefpodoxime. So table 72.2 works pretty well to show you all of that. Cephalosporins will get to most body fluids and tissues, which is nice. However, you have to be cautious in ocular fluids. It's really hard to get good penetration, but you get good penetration into the pleura, the pericardium, and the peritoneal fluids, which is good. You don't have good, reliable CSF penetration by first and second generations, but CSF levels with third, fourth, and fifth are generally sufficient for bactericidal effects. Elimination, practically all the cephalosporins are eliminated by the kidneys. Ceftriaxone is actually the one largely eliminated by the liver. So consequently, dose reduction is unnecessary in renal failure for ceftriaxone. They're pretty well tolerated. These drugs are pretty well tolerated and considered pretty safe. Hypersensitivity is the most frequent adverse event. Maculopapular rash that develops several days after the onset of treatment is most common. But severe immediate reactions like bronchospasm and anaphylaxis are rare, thank God. If during the course of treatment you get allergies like urticaria, rash, hypotension, bronchospasm, trouble breathing, the cephalosporin should be discontinued immediately and they should be given the label of allergy to cephalosporin. Remember to pay attention that there's about 1% of penicillin allergy that has the cross sensitivity to cephalosporin. So if they have a severe allergy to penicillins, they don't get a cephalosporin. Cephalosporins, there's two of them, cefazolin and cefotetin, can induce a state of alcohol intolerance. So if a patient were to take those drugs and then drink alcohol, they get the anabuse-like reaction. It could be very dangerous. So that would be a point of education. There's a few cephalosporins that promote bleeding, one of which is the cefazolin, Ancef, and the ceftriaxone, Rocephin. So in the hospital, we use those drugs a lot, and they can promote bleeding because they can interfere with the vitamin K metabolism. So we have to be careful with that. Therapeutic use, most of the role of the cephalosporins, they're broad spectrum and bactericidal with a high therapeutic index. So they're very safe. We use them a lot. The first and second cephalosporins are rarely drugs of choice for active infections. We use those typically for like prophylactic things. In most cases, equally effective and less expensive alternatives are available. The third generation agents have qualities that make them preferred for several infections. They're very much well used. Fourth and fifth are active against more resistant organisms. And the fifth, again, is effective against MRSA and healthcare associated pneumonia. So the prototype for the cephalosporin is cephalexin. For carbapenem is imipenem, and then we have vancomycin. I like that the book talks about, in terms of the cephalosporins, aside from a cost, there's frequently no rational basis for choosing one over the other in outpatient settings, but specific infections in a specific host oftentimes will point you to one generation or the other. So antimicrobial spectrum versus adverse effects versus pharmacokinetics could also make the decision for you of which generation of cephalosporins you would want to give. All cephalosporins can also produce or promote C. diff, so you have to be just as careful to have them report the frequency of their diarrhea. All right, next drug class are carbapenem. These are beta-lactam antibiotics that have a very broad spectrum of antibiotic use. But none of them are active against MRSA. So a key point to remember, carbapenems are great. They're really broad drugs, but none of them work against MRSA. There's 4 of them. All 4 of their dose or their route has to be parenteral. To delay the emergence of resistance that sooner or later is bound to happen, but to delay it, they should be reserved for patients who cannot be treated with a narrow spectrum agent. You will absolutely have the stewardship squad hunting you down with laser-like precision if you give a carbapenem inappropriately, as they should. Okay, first one they talk about is the imipenem, which is Promacin. It's a beta-lactam antibiotic, extremely broad, which is great. It's broader, in fact, than nearly all other antimicrobial drugs. So because of that, imipenem may be of special use for treating mixed infections with anaerobes, Staph aureus, and gram-negative bacilli if all 3 of those are thought to potentially be involved. Okay? It is supplied in a fixed dose combination with cilastatin. So you have imipenem cilastatin as well. That is added because it inhibits the destruction of the imipenem by renal enzymes. Okay. Imipenem binds to 2 penicillin binding proteins. It binds to 2 of the PBPs, causing weakening of the bacterial cell wall with lysis and death. Antimicrobial effects are enhanced by the drug's resistance to practically all beta-lactamases and its ability to penetrate that gram-negative cell. Okay, that's awesome. They're good drugs. They're fairly low toxicity too. It's active against almost most of bacterial pathogens, including organisms that tend to be resistant to other antibiotics. It's highly active against gram-positive cocci, gram-negative cocci, and bacilli, gram-negative bacilli. It's the most effective beta-lactam for use against anaerobic bacteria. It is not absorbed from the GI tract, and so you have to give it IV. It's distributed to most of the body fluids and tissues, and it can penetrate well into the CSF. It is renally eliminated. When you give imipenem alone, it's inactivated by dipeptidase, which is an enzyme present in our kidneys. So drug levels in the urine are low. To increase urinary concentration, it's given with the cilastatin, which is a dipeptidase inhibitor. And when used in combination, 70% of the imipenem is excreted unchanged in the urine. So it works very, very well and can really keep the imipenem from being not changed. Adverse effects, GI, nausea, vomiting, diarrhea are the most common. Superinfections can occur with bacteria or fungi in about 4% of patients. There's very rarely reports of seizures. You can have hypersensitivity reactions, and patients allergic to other beta-lactam antibiotics may be cross-allergic with imipenem, but it's less than about 1%. Of note, imipenem can reduce the levels of valproate, right, that seizure drug or the mood drug, so breakthrough seizures have occurred. If possible, use of imipenem and valproate should be avoided. And if you have to use it, you need to give them another supplemental anti-seizure medication. Okay, it's very broad spectrum. It can also treat Pseudomonas, but when it's the only drug that's been given to treat the Pseudomonas, we've seen more resistance emerge. So they say imipenem should be combined with another anti-pseudomonal agent, which is good to know. So carbapenems in general, we have to watch their renal function. We have to use them appropriately. If they're on valproate, they need to have another seizure medication. By the way, the other point I wanted to point out, cephalosporins and carbapenems, you have to look very carefully at pregnancy and breastfeeding, by the way. Okay. The next drug they talk about is other. The other inhibitor of the cell wall synthesis is vancomycin. It's the most widely used antibiotic in hospitals today. It's given for C. diff infections, MRSA, and serious infections with susceptible organisms in patients allergic to penicillins. The major toxicity is renal failure. You have to monitor their renal failure. Even if they had normal kidneys to start with, you need to monitor it because it can cook their kidneys very easily. But unlike the other drugs we've talked about in the bacterial cell wall issue, vancomycin does not contain a beta-lactam ring. All right, as in most cases of the beta-lactam antibiotics, vancomycin also inhibits cell wall synthesis and therefore promotes bacterial lysis and death. But it's interesting because it does not interact with the PBPs. Instead, it disrupts the cell wall by binding to molecules that serve as precursors for the cell wall synthesis. So through a different pathway, it messes up the ability to maintain the integrity of the cell wall. The cell wall will break down and you'll have lysis and death. So it's lumped in with the inhibitor of cell wall synthesis, but it works differently than the other penicillins. Okay. Of note, vancomycin is only active against gram-positive bacteria. So gram-positive vancomycin is especially active against staph and Staphylococcus epidermis. It also is effective against C. difficile. Absorption from the GI tract is poor. It's given parenterally for most infections. The only time you give vancomycin orally is for C. diff because it has to work directly in the gut. And actually parenteral C. diff is parenteral vanco is ineffective against C. diff. It penetrates most body fluids. It will penetrate the CSF, but it's really hard to get it in concentrations that's actually going to help treat meningitis. You may actually have to give intrathecal dosing directly into the CSF. It's eliminated unchanged by the kidneys. Again, it should be reserved for serious infections. Specifically, we want to cover MRSA or staph epi. Most strains of these bacteria are all still sensitive to vancomycin. It's the drug of choice as of 2021 for severe C. diff, but not for mild C. diff. I will tell you, and I'm not going to worry too much about it for the purpose of this course. C. diff, you'll learn later in your decision and management courses that there's some newer guidelines out on C. diff and its role between metronidazole, vancomycin, and then fidaxomicin. So, but for the purpose of this course, it is still used to treat C. difficile, and it is something to consider for that. It's an alternative to penicillin or cephalosporin if you have an allergy to beta-lactams. Remember, though, it really has to be monitored for kidney function very closely, especially if they're really sick and they're getting other nephrotoxic drugs or their intake isn't good. To minimize the risk, serum levels of the vancomycin should be monitored. For C. diff infections, remember, maybe you don't know this yet, but C. diff is a gram-positive spore-forming anaerobic bacillus, okay, but it's still gram-positive, and it infects the bowel. Injury results from the release of two toxins, A and toxin B. Symptoms range from mild, you get a low-grade fever, nausea, some diarrhea, some maybe cramping, to very severe, which is the toxic megacolon, pseudomembranous colitis. You can perforate your colon, you get sepsis and death. Clostridial difficile infection, CDI, is more common and more severe because there's a more virulent strain, NAP1B1027. And so this bacteria has continued to grow, and we know that now it releases more toxins than the previous strains. So the rate of infection in some hospitals for C. diff exceed those now of MRSA. But we can still treat the C. diff pretty well typically. C. diff is almost always preceded by the use of antibiotics. So when you give those antibiotics, remember, they allow normal flora to be altered. So we kill off the normal gut flora, and that allows then the C. diff to flourish. But we also know that there's a few antibiotics that are much more prone to doing this than others, one of which is clindamycin, second and third generation cephalosporins, and fluoroquinolones. So if you've had someone in the hospital and they were treated with an infection with ceftriaxone and then they get diarrhea, we have to think C. diff. If they were treated with levofloxacin for something, we have to think C. diff. Got to keep that in your differential if they get diarrhea. They actually state in your book that because we overused probably for fluoroquinolones, that's probably where the NAP1B1027 strain came from. Resistance sucks. You get Clostridium difficile by acquiring or ingesting, the C. diff spores, which are shed in feces. So any object that feces can come in contact with, like toilets, bathtubs, rectal thermometers, can be a source of infection. The spores can live a long time on a surface. So in a hospital, spores are transferred to patients primarily through the hands of healthcare workers who have touched a contaminated person or object. The spores of C. diff are resistant to drying, temperature changes, and alcohol. So, this is the terrifying part, viable spores can remain in the environment for weeks. Okay, there's the definition of C. diff that has been a little bit altered in the last few years. Intestinal damage is caused by toxins A and toxins B, which attack the lining of the colon. You can get a wide variety of severity of symptoms. If they're very ill, you have to watch for dehydration, electrolyte disturbance, sepsis, etc. Another troublesome part about Clostridium difficile is that you have a high recurrence rate, varies between 15 and 30%. Most people will get it because they were already treated with an antibiotic. The interesting thing is that we treat it, you get it because you are on antibiotics, but we treat it with antibiotics, which is kind of funny to me, and it can really kind of flabbergast people. The other important thing is that really most times it's considered that you don't get to count the days of antibiotic therapy until you stop the other one. So if they're in and they're being treated for cellulitis and they're on ceftriaxone, and then they get diarrhea and you test and they do have C. diff and they say, okay, they need 10 days of Vanco, you don't start the day one of Vanco until their last day of the other antibiotic. FYI. So as soon as possible after you get the C. diff, the antibiotic that facilitated the C. diff should be stopped. And sometimes that can even be enough to cause the infection to resolve on its own. But you oftentimes will treat for the C. diff anyway. Okay. If they've had recurrence, that can change how you dose and what drug you give, those kind of things. There's a pulsed vancomycin with a taper that could be attempted. Then we have the fidaxomicin. Then we have options with metronidazole. So your book gives you a option for treatment of C. diff. I'm not going to ask you for doses. I'm really not going to ask you to memorize this, but I would want you to be able to refer back to your book of where you think you might need to go to find this. Okay. We do have some alternatives to vanco and fidaxomicin, like rifaximin or even a monoclonal antibody, but that's getting very specific. There is ways that we should understand how to decrease the spread of C. diff. You should use antibiotics judiciously. You should isolate patients in a private room, wear gown and gloves when entering the room. After contact with the patient with C. diff, wash your hands in soap with running water. Most of the alcohol-based hand rubs will not kill the spores, so that's not enough. Use disposable medical equipment, and you should really decontaminate the surfaces around that room or that area. The next drug they talk about is telavancin. It's the first representative of this new class of drugs, which is lipoglycoproteins. It's a derivative of vancomycin. It's active only against gram-positive bacteria like vanco. It does kill the cell wall from two ways. First, very similar to vanco, the telavancin inhibits bacterial cell wall synthesis, and it binds to the bacterial cell membrane and thus disrupts membrane function. It's approved only for IV therapy of complicated skin and skin structure infections caused by susceptible strains of the following gram-positive organisms: staph, both MSSA and MRSA, Streptococcus pyogenes, and Streptococcus agalactiae, Streptococcus anguinosus, and Enterococcus. To delay development of resistance, again, telavancin should be reserved for treating vancomycin-resistant infections or for use as an alternative to linezolid, daptomycin, or tigecycline in patients who cannot take those drugs. It's not your first choice drug. It's used very specifically. We're trying to hold on to it and decrease the rate of resistance. It can cause taste disturbance, nausea, vomiting, and a foamy urine, which is kind of unique. As with vanco, rapid infusion can cause red man syndrome. So you can get this flushing, you can get a rash, you can get itchy, you can get tachycardic and hypotensive. It's not a true allergy, it's just red man syndrome. And that's really beyond what we want to talk about here today. This chapter gets really heavy, so I'm not going to go into that a lot. But there is a way that you can cause the red man syndrome with your rate of infusion. Telavancin has a black box warning because when used to treat hospital-acquired or ventilator-associated bacterial pneumonia in patients with poor renal function or a creatinine clearance of less than 50, it has an increased mortality when compared with vanco. It can prolong the QT interval, but we really haven't had reports of severe arrhythmias from it. But you have to be cautious with that. You have to be really careful, like vanco, with other drugs that can damage the kidneys or prolong the QT. That's telavancin. Last one, I think, is Trionam, which is Azactim. I love this drug. People a lot of times forget about it, but it's a good thing to have in your arsenal in the back of your mind. As Trionam belongs to a class of beta-lactam antibiotics known as monobactams. So they have a beta-lactam ring, but the ring is not fused with a second ring. So the aztreonam binds to the penicillin binding protein 3. So as with most beta-lactam antibiotics, the drug inhibits bacterial cell wall synthesis and thus promotes cell lysis and death. The drug does not bind, though, to penicillin binding proteins produced by anaerobes or gram-positive bacteria. Aztreonam has a narrow antimicrobial spectrum. It's only active against gram-negative aerobic bacteria, such as Neisseria species, H. flu, Pseudomonas, and Enterobacterales like E. coli, Klebsiella, Proteus, etc. Aztreonam is highly resistant to beta-lactamases and therefore is active against many gram-negative aerobes that produce them. So it's a very specific window of drugs to use, but it's a good one to have in your back pocket as a choice. Aztreonam is generally well tolerated. Its most common things can be pain and thrombophlebitis at the site of injection. It differs greatly. Okay, this is where this one really is in use in hospital settings. It differs greatly in the structure of penicillins and cephalosporins. So you can use it in people that have those allergies. So if you have a penicillin allergy, but you really wanted to use that penicillin, think in your mind, could I use Aztreonam? Oh, I lied, one more drug, fosfomycin. It's a unique antibiotic approved for single-dose therapy in women with uncomplicated UTI caused by E. coli or Enterococcus facialis. It also kills the bacteria by disrupting synthesis of the peptidoglycan polymer strands that compose the cell wall. Fosfomycin may be done with or without food, and it's really specific to UTI in women. It's a random drug stuck in here, but it technically also is a bacterial cell wall. Okay. All right, you hung in there. We managed to get 2 chapters done, 71 and 72. So we'll come back for 73.